Wolfgang provided me with the title of this talk, which is in the form of a question. So I could give you my one-word answer right now, sit down, and we could go get some coffee and take a break a little early. But I was told that I have to speak for 12 to 13 minutes, so you're going to have to wait about 20 slides before you get my take on this controversial question. About 15% of patients who have colorectal cancer will develop peritoneal metastasis at some point during the course of their disease. And there are a number of risk factors for the development of peritoneal metastasis, including advanced T-stage and tumor perforation. Historically, the survival of patients with peritoneal metastasis from colorectal cancer treated with 5-FU leucovorin has been very poor, with a median survival rate of about 6 months. However, the results are now better with more, quote-unquote, modern chemotherapy. For example, in one analysis of 2 pooled studies from NCCTG of patients with peritoneal metastasis treated primarily with oxaliplatin or irinotecan, the median survival rate was about 13 months. If the patients received FOLFOX, it was almost 16 months. Nevertheless, the survival rate for patients with peritoneal metastasis, even treated with modern chemotherapy, is very poor, as shown in the blue Kaplan-Meier curve, with very few long-term survivors. Cytoreductive surgery plus hyperthermic intraperitoneal chemotherapy was first described by Dr. John Spratt at the University of Louisville in 1980. Dr. Spratt's grandson was just a chief resident who graduated from our program last year. He had no idea that his grandfather started this whole nonsense. So, this is a 2-component treatment. Cytoreductive surgery is a systematic effort to remove all or nearly all tumor nodules in the peritoneum. This procedure often requires a multivisceral resection to get a complete cytoreduction. Even after a complete cytoreduction, patients still have microscopic peritoneal disease. And so HIPEC is meant to treat any microscopic residual disease at the same time or immediately following the cytoreduction. So HIPEC delivers high local concentrations of chemotherapy under hyperthermic conditions. And this is how we do it, and this is how I learned how to do HIPEC.
Number 1 rule of surgery is limit exposure. Good. Keep your hands clean, your incisions small, and your wounds covered.
I've removed the tumor and placed the catheters. Now I'm going to flood the abdomen with heated chemo. It allows a greater concentration of drugs to be delivered directly to the affected area, and the heat helps target the cancer cells while leaving the normal cells virtually unaffected. Okay, start perfusion. Okay, we'll place him in Trendelenburg, then reverse Trendelenburg as we agitate the abdomen.
It's an aggressive shake there.
Chemo really washes everywhere.
So thank you for the opportunity to speak. Are there any questions? It's funny. This is season 6 of Grey's Anatomy, and HIPEC received a lot of national attention after this episode, and HIPEC centers started popping up all over the United States as a result. So we have limited prospective randomized data demonstrating the effectiveness of cytoreductive surgery plus HIPEC for colorectal cancer. The best single study that we have is this prospective randomized controlled trial, single center study from the Netherlands that was published in 2003. In this study, 105 patients, primarily with colorectal cancer, but there were some appendix cancer cases thrown in there, had peritoneal metastasis, and they were randomized to either systemic chemotherapy and palliative surgery if needed, or to cytoreductive surgery plus HIPEC using mitomycin C plus systemic chemotherapy. This trial showed a significant survival benefit for patients treated with cytoreductive surgery plus HIPEC. This is the Kaplan-Meier curve from this trial, showing a pretty impressive survival benefit for patients treated with HIPEC. There are a number of limitations of this study. I think the biggest limitation is that standard chemotherapy in this trial is not standard chemotherapy today. And unfortunately, we don't have a prospective randomized trial today comparing cytoreductive surgery plus HIPEC versus modern chemotherapy. We do have some retrospective data that again suggests that there's a survival benefit with a combination of cytoreductive surgery plus HIPEC. In one study of 96 patients, some patients underwent modern chemotherapy, other patients underwent cytoreductive surgery plus HIPEC. In the chemotherapy-only cohort, those patients all had potentially resectable peritoneal nodules, no extra abdominal disease. So the authors tried to match these patients as closely as they could. As you can see, the median survival with modern chemotherapy was about 24 months, but was 63 months for those patients treated with cytoreductive surgery plus HIPEC. Additionally, multi-center registries have also suggested a survival benefit with a combination of cytoreductive surgery plus HIPEC. In one multi-center study, Esquivel included 609 patients treated with cytoreductive surgery plus HIPEC. The median survival rate was 41 months. Remember this trial, this study, I'm going to talk about it again. And finally, a systematic review of 2,500 patients with colorectal cancer treated with cytoreductive surgery plus HIPEC. The 5-year survival, 40%, median survival, 33 months. There are a number of predictors of which patients are likely to benefit from this treatment. One of the most powerful is the completeness of cytoreduction score, or the CCR score. So the more residual disease you have at the end of the operation, the worse your overall survival rate. Another strong predictor of survival is the peritoneal cancer index, which is a score which measures the volume of interperitoneal disease before you start the cytoreduction. So clearly, as you can see, the higher the volume of peritoneal disease, the lower, the worse the long-term survival. HIPEC in Europe is different than HIPEC in the United States. The Europeans primarily use a 30-minute perfusion with oxaliplatin. In the United States, we primarily use a 90-minute perfusion with mitomycin C. We do not have prospective randomized trials comparing these two approaches. However, one large retrospective registry found no survival differences between these two approaches with oxaliplatin versus mitomycin C. So far I've shown data from prospective randomized trials, from multi-center registries, from systematic reviews, that the combination of cytoreductive surgery plus HIPEC is associated with an improved survival rate for patients with peritoneal metastasis from colorectal cancer. But do we need both components of this treatment? In other words, to get back to the title of my talk, does HIPEC provide any survival benefit to cytoreductive surgery alone? And this, thank you for a few laughs. So this question was the center of a prospective randomized trial from France. The results of this trial were presented at the 2018 ASCO meeting. In this trial, 265 patients with peritoneal metastasis from colorectal cancer underwent complete cytoreductive surgery, and then they were randomized to either HIPEC with oxaliplatin or no HIPEC. All patients received at least 6 months of systemic chemotherapy. With a median follow-up of 64 months, there was no survival benefit for HIPEC in this study. Instead, HIPEC was associated with a significant increased grade 3 to 5 toxicity at 60 days. So in this prospective randomized trial, we found no oncologic benefit and higher toxicities with HIPEC compared to cytoreductive surgery alone. There are some criticisms of this trial. Number one, the surgeons used oxaliplatin. In the United States, we primarily use mitomycin C. The surgeons used a 30-minute perfusion. In the United States, we use a 90-minute perfusion. These data, although presented a year and a half ago, still have not been published in a peer-reviewed journal. But probably the most important weakness of this trial is that the investigators are French. There is support. I don't want to get any emails from any French people out there. There's support for this trial. One is that this is a well-designed, prospective, randomized clinical trial. There are multiple high-volume centers, very experienced HIPEC surgeons. I think most importantly, the survival rates for the non-HIPEC arm are very similar to the results for patients treated with HIPEC in other studies. So I talked about the Esquivel study. The median survival with cytoreductive surgery plus HIPEC, primarily with mitomycin C, was 41 months, which is exactly the same as the survival rate with cytoreductive surgery alone in the French trial. And looking at Jake's data, the median survival rate of about 41 months is pretty similar to the survival rate for patients who have colorectal liver metastasis. So I performed my first HIPEC procedure in 1994 when I was a fellow at MD Anderson Cancer Center. I started our HIPEC program in 2002. So in 2019, I think that HIPEC is no longer indicated for patients with colorectal peritoneal metastasis. And this is not really surprising. HIPEC is one drug, one treatment, essentially. And that's not how we treat GI cancers. So for the adjuvant therapy of colorectal cancer, 3 drugs, 12 cycles. Adjuvant therapy for gastric cancer, 4 drugs, 8 cycles. Pancreatic cancer, 4 drugs, 12 cycles. But maybe HIPEC is the exception, that 1 drug, 1 cycle works. However, the one prospective randomized trial that we have shows no benefit. It's interesting to review the NCCN guidelines regarding HIPEC over the last several years. So in 2016, HIPEC was not recommended outside a clinical trial. In 2017, HIPEC could be considered in experienced centers. In 2018, after the French data became public, HIPEC was considered controversial in 2019. Now, the 2020 NCCN guidelines regarding HIPEC are not out yet, but I've heard from a very reliable source that they're just going to defer to Gray's Anatomy. So, in conclusions, in 2019, for patients with peritoneal metastasis in colorectal cancer, selected patients can undergo cytoreductive surgery plus systemic chemotherapy, but that HIPEC should be reserved for randomized clinical trials. Thank you very much.